Thank you so much for joining us today for our last Rural Health Work Group of 2024. My name is Emily, and I'm one of the Site Engagement Coordinators with MVC. It is my pleasure to be facilitating this work group with you today. All right, just a couple of housekeeping notes before we get to our presentation today. First, as you might have noticed, this session is being recorded. The slides and the recording will be shared with you following the work group. Just give us a little bit of time to get that link together on our YouTube channel, and then it will be shared with you via that follow-up email. Additionally, we will have an opportunity for questions and discussion. We're hoping for some pretty fruitful discussion following Toni's presentation today. If you do have a question come up throughout the presentation, we'd ask that you hold that or send it to us via the chat, and we will bring all of those up at the conclusion of the presentation. And then lastly, your feedback is very, very important to us. You've been keeping up with completing all those surveys throughout 2024. Following the completion of the work group today, if you can please complete the post-work group survey. That link will be provided to you in the chat at the end of the work group, as well as in the follow-up email. All right, so today's Rural Health Work Group is going to feature a presentation by Toni Moriarty-Smith. Toni joined McLaren, Northern Michigan in July of 1984. Long time with McLaren.
When I was 12.
Yeah. So during her tenure, she has held clinical and leadership roles, including nurse manager for the maternal, child, and health, director of professional nurse practice, and the Magnet program director. In 2022, Toni was named the director of quality and clinical risk. And in this role, Toni oversees all quality and performance improvement initiatives, monitors clinical safety within the organization, and conducts system root cause analyses to promote a culture of safety at McLaren Northern. Toni has also worked for the American Nurse Credentialing Center as a Magnet appraiser since 2019. She received her bachelor degree of fine arts in 1981 before beginning her nursing career. She went on to receive an associate of nursing degree from North Central Michigan in 84, but I don't think we've quite hit 2084 yet.
Yeah, right.
Probably 1984. Yeah. And a master's degree in nursing and health education in September of 2009. Throughout her career, she has been a staff nurse, a team leader, clinical supervisor, and nurse manager. Her clinical background includes pediatrics, neonatal obstetrics, nursing education, and quality. So it is my pleasure to introduce Toni as our presenter for today. And Toni, just let me know whenever you're ready for me to progress your slides.
Perfect. Thank you, Emily. So I want to preface this presentation with the fact that I am not the ED expert. I have a team of leaders and clinical nurses and physicians who have done amazing things in our emergency department. Post-COVID and during COVID. So, our world changed. COVID changed our world. Not that we didn't have challenges before COVID, but like everything else, they were amplified during that period of time. So I'm going to talk to you today about some of the challenges in the ED and what we've done to address them. Go ahead. So, in a nutshell, the challenge is overcrowding in our ED. Now, of course, that wasn't in the heat of COVID because people were afraid to come to the ED. But as COVID wound down, we had our EDs were packed, our waiting rooms were packed, our wait times in the waiting rooms were unprecedented for us. We had, prior to COVID, maybe an hour wait time in our ED. And, when people started coming back to healthcare, we were having 6 to 8 to 12-hour waits. So our community was stunned and very unhappy with this, as they should have been. Some of the reasons were skilled nursing facility holds. So some of the legislation that started impacting skilled nursing facilities around falls. So, they became very particular about accepting patients with high fall risks. Also, their staffing challenges were the same as ours. So, were they able to staff all of their beds? We ended up holding people in our ED that needed to go to long-term care facilities. Same with behavioral health patients. Behavioral health units are few and far between in the state of Michigan, particularly children and adolescents. And we were keeping them down there in the ED for 2 hours, they're not 2 hours, but for 2 weeks sometimes. The acuity of patients became higher because they hadn't had healthcare regularly. We started seeing a much higher acuity of patients. And we were boarding patients down there because we didn't have staffed inpatient beds. So our staffing was significantly impacted during COVID. People went to be travelers. I don't know, they retired. They just decided that they didn't need to work anymore. I don't know what it was, but post-COVID, we lost probably about 60% of our staff during COVID. We were using travelers and recruiting like crazy. But all of these things really impacted our ED throughput. It really impacted the amount of people that came to the ED and left without being seen. It increased the door to doc time and really decreased our patient satisfaction. So we knew we had to do something. Go ahead, Emily. So instead of doing something, we did many things because we didn't know what exactly was going to work. So I'm going to talk to you today about the things that we implemented. We addressed workflow through a fast track and a PITS process, and PIT is physicians in triage. We worked to open inpatient beds. We cross-trained the PCT role to HUC and phlebotomy. We changed our staffing model in our ED triage, and we implemented waiting room volunteers. And these are things that impacted overall patient satisfaction, overall our ED throughput. Go ahead. So fast track and physicians in triage. So we went to the literature and we really did a lit search around what can we do, what are best practices in EDs. And we found this fast track and physician in triage. It showed that overall wait times can be decreased by 35%. And even for those high acuity patients, so the patients who you're planning to admit, you can decrease the boarding time over 70%. So in March 2023, we began to work on implementing the fast track and PIT process. Go ahead. So we identified, the first thing that we did is that we identified triggers, because not always do you need this process and it takes resources. So we wanted to use it when it was most needed. So we wanted to make sure that our RNs were in full assignments, and that was contributing to wait times. We wanted to make sure that our triage nurse was able and had the resources to be able to start protocol orders, and that process was in place before we started to move to fast track PIT. We wanted to make sure we had enough providers because providers were a commodity as well. And we wanted to make sure that we had charts in the rack and that this was a priority situation. So when all those triggers are met, we pulled the ED providers and the ED team leaders into a huddle to say, okay, we think that we need to move to a fast track phase. If everyone was in agreement, we go to step one. And that step was that an ED provider and an ED triage nurse huddled to review the patients that were in the waiting room. We really were looking for triggers. The three triggers was that one, in reviewing those patients in the waiting room, there was a fair amount of them that were probably low acuity. Or that we had patients in the waiting room where we already had triage, we had implemented protocol orders, and we needed to do the next step. And finally, also that people were threatening to leave, that their wait times were extended, and we were afraid that we were going to lose those people. So depending on which was the priority of those triggers, we came up with the fast track solution. So if we had a lot of low acuity patients in the waiting room, we would open up fast track and with a dedicated provider, and we'd actually go out to the waiting room and start assessing patients. You know, what are your needs? And if it was a sore throat, we have, it's called the visitor ante room. We would take those people into that ante room, do a quick exam, and write a script and discharge those patients. Now, these patients also had been triaged, so they were already in our system, because that's always a big piece of this fast track is how do you bill for the patient if they're not in your system. If they had protocol orders already placed and we are waiting on physicians to see them, again, physicians would evaluate the patients. If we have room in our triage, or sometimes we use that visitor ante room, they would then identify with the lab results we got back or the x-rays we got back, could we send these people home, or did they have to be seen in an exam room? And so we were able to get some of the people out of the waiting room just because we were waiting on that strep result, or waiting to see, you know, was it a sprain or a fracture? So if there was a lot of people that were waiting, had been waiting a long time, we would have the provider kind of go in order of people who had waited the longest and take them into that visitor ante room and do an assessment. And then we were able to start the process there if they needed additional tests. That's kind of when the triage wasn't working anymore and we needed to go to that next step. So it's a little confusing because there was a lot of ways that fast track worked, but you'll see that our goal to decrease length of stay, are left without being seen, and increase safety and satisfaction were really impacted by this. Go ahead. Another thing we did to kind of get people seen and triaged is that we cross-trained all of our PCTs to phlebotomy. So during this time, not only was there nursing shortages, we had phlebotomy shortages. And what was happening is they would say, we don't have anybody to draw phlebotomy between 7P and 7A, so the nurses are going to have to do it. So what that did was it took time away from the nurses who were trying to triage patients, and just was slowing down the whole process. So we implemented a PCT 3 position. Those PCTs were cross-trained to phlebotomy. They were also cross-trained to do EEGs. They got a higher wage for that, which was a huge satisfier for them. And they really helped throughput so that we could get those people triaged, we could get the protocol orders implemented, and that sort of thing. So that is another piece of that workflow change. Go ahead. Another workflow was that we only had one triage RN all day. If we had a call in, sometimes we would have to pull from the back to bring people into triage. So what we were seeing was this increased volume and acuity. That was, one triage had been fine prior to COVID, but now we had all of this volume. So we adjusted the staffing schedule to have to bring a second RN, triage RN in from 11A to 11P. It kind of got us through those busiest times. The other thing we did at the same time is we began to hire student interns, and this is not a new concept. I have to tell you, when I went to nursing school way back in the 80s, I was hired as an intern, but somehow we got away from that. I think we all of a sudden had enough nurses and we didn't need to do that. So we kind of used old school kind of staffing model, and we have a community college here in town. And after their first year, we offered them all intern positions. And a lot of them took advantage of it. And we added some of those interns into the mix, into the ED. So they were just an extra pair of hands. They could help transport patients. They could round on the patients, and it was very helpful. Go ahead. And this is kind of what we found. So that first quarter of 2023, when we implemented the fast track and the new staffing model, we really had seen the average time from ED arrival to ED departure. So these are discharged patients hitting an all-time high. So the median minutes you can see prior to COVID in 2014 was 121 minutes, and we had reached 222 minutes in the first quarter of 23. So that was a real impetus for us to make change. And you can see it started to come down in the third quarter. And by the fourth quarter, we were down to 147. We had a little blip in 2024. I think it was a staffing issue, but now we're down to 100. In third quarter of 2024, we were down to 132 minutes again, very close to our baseline. So we are very happy with that. Okay, go ahead. We also monitored our patient satisfaction. So overall satisfaction with doctors and overall satisfaction with nurses. You can see that second quarter 2023, we really had hit a low point, and the things that we had put in place has really impacted that, and we're back up to a top box of about 75. So go ahead. So moving to kind of those patients who were going to admit, some of the challenges we had was we had so many RN vacancies, we weren't able to staff all of our inpatient beds. And because we were really worried about our financial stability, the priority was to open up OR rooms. So we have 10 OR rooms. In 2023, we were only running 7. So that was due to staffing, also due to some physician shortages. Before really we worried about boarding patients, we kind of put the horse before the cart, and we started bringing people into the ORs. We opened up our ORs. We brought a bunch of OR travelers in, and we were just cranking patients through our surgical services, which was great financially for us. But what happened was it took up all of our inpatient beds and didn't allow throughput through the ED. So we knew we needed to address staffing and RN staffing. So in order to retain nurses, we did a rebase of RN wages. We significantly increased RN wages. And through the years, there was all kinds of initiatives about, we need to get nurses in. So we gave a bunch of, we increased the start rates, which was a huge dissatisfier to those people who have been here for 10, 15, 20 years, because now you have all these brand new nurses making more money than them. So the rebase was looking at everybody's wages and basing them on years of experience and tenure. We had a huge initiative to re-recruit former employees. So we had a list of former employees. Our HR actually brought in some contracted help, and they made cold calls and sent out basically invitations saying, we want you back. We've addressed wages. We're working on increasing throughput. We have high quality. And we really did re-recruit about 20% of the people that we lost. Because we needed to get rid of some of our contract RN expenses, we had an initiative to transition those contracted RNs to temp RNs. So we cut out the middleman, basically. They usually had to finish out their contract, and some travel agencies have different rules than others, but we were able to transition our travel nurses to temp RNs, about 70% of them. And then from there, we brought additional travel contracts in as we needed to open up those beds. Go ahead, Ellie. So this was a long process, really throughout 2023, we worked on this. First thing we did was try to convert those travelers, and then we did the wage rebase in the second quarter. Once we had wages where they needed to be, we re-recruited former nurses. And then in the end, we were able to assess, now what do we need for travel nurses? So you can see in 2023, our boarding minutes just went up, 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 up. After all of those things were put in place, we started to see that come back down. And so while we're not at our baseline, which was 61 minutes for boarding, and I meant to put a slide in here. So we count boarding minutes. Those minutes start after 30 minutes post admission order. So from the time the physician puts an admission order in, you have 30 minutes to get them out of the ED. After that 30 minutes, we start counting them as boarders. So you can see in 2021, people on average were there an hour and a half. So 30 minutes after the order was written, and then maybe another hour. So when it got to be 400 minutes as being the average, and some of them were much longer than that, we knew that this was a real problem, and we've got it down to about 216. So they're still down there a while, but we're going in the right direction. Go ahead. So this is the percent of admissions that we still board. So the percent of people who are still staying down there over 30 minutes. And we really have not been able to move this bar as much as we would like to, because still about 87 of the patients we admit are down in the ED for over 30 minutes. But it's another way to look at it. So we have a patient and family advisory council. And as we were talking to them about the challenges in our ED, because they are great about being the voice of our community, and ED wait times, that they would bring to us these horror stories that they were hearing in the community. And as we talked to them about what our barriers were, they actually suggested that they said, how can we help? Can we volunteer to help you? And so we brought our ED director into the patient and family, and we developed a role for volunteers in our waiting room. And these volunteers many of them are people from our patient and family advisory council. So while we would love to have somebody down there 24/7, that's totally unrealistic. So we kind of try to hit that 11A to 7P kind of time, because that's when most volunteers are more likely to want to volunteer, and Monday through Friday. We don't always have them down there, but that's our goal. So their responsibilities are to, as people come in, make sure they know how to get to the registration, make sure that there's a place for them to sit if they have to wait to get registered, providing them some basic information about the ED process and wait times. And interesting, one of the things that we saw happen is as our wait times were longer, people would say, I'm going to go run out to McDonald's and get something to eat because, I've been here 6 hours. And when people leave our waiting room because of EMTALA regulations, they come off our boarding, they come off our wait list. And so they have to re-register when they walk back in. So volunteers kind of give them this information saying, you can't leave because, it's going to take you out of the queue. They would love to be able to feed them and give them bottles of water, but if you're going to have to go to surgery, you can't have food and water. So we put a warming blanket in the ED, and we allowed them to come out and take warm blankets to people. They was appreciated by the patients, and it made them feel like they were doing something to provide comfort. They would round, and as people were saying, how much longer, they would reiterate, we really have to see people based on their acuity. And so while I know this is a long wait, please understand that we're taking care of the sickest first, and we will get you as soon as we can. They cleaned it up, they organized it, they had magazines, they all brought in magazines from home. And then for family members that were waiting, they would direct them to the cafeteria or whatever and provide them updates on their family members. Go ahead. So we looked at our Press Ganey top box scores for wait times and staff cared for you after we put those volunteers in, and we did see a pretty significant increase in those top box scores. So as far as staff cared for you, we're back up to 70% from 50, and wait times has gone from 30 back up to about 57. Our left without being seen rates in April of 2023, the average left without being seen, our goal has always been 2. We got up to 9 and 10. And I have to say, in 2022, it was actually worse than this. I think the highest we saw was around 15 people a day leaving without being seen. But we put the volunteers in. By December of 2023, we really have hovered around our goal of 2. Summers are busy for us. Our population increases significantly up here in northern Michigan. So we usually see a little pop in the summer, but I didn't have the data in time to put in this graph, but we're back down to below 2 now. Okay. So I'd like to say that everything's wonderful and we fixed all of our problems, but we still have ongoing challenges with adequate staffing of physicians, rad techs, phlebotomists, all of those things. We're really challenged up here with housing. Affordable housing is a problem. Recruiting people whose husbands or wives need to have a job. There's the job market up here is somewhat limited. So recruiting up here has always been a problem. It's just a bigger problem now. And to be completely transparent, some of our physicians are more engaged in the PIT process than others. So some of them, you really have to twist their arm when they're meeting with the triage nurse and the team leader, and they're like, oh, it'll be fine, it'll be fine. And others are ready to jump in and do what they need to be done. So, you know, you have those inconsistencies. And we've continued to see an increase in patient and OR volumes. And so specifically in the summer months and now getting into the winter months with our ski hills, we see more traumas. So that's just an ongoing up and down census variation that challenges us. Go ahead. So that's just kind of a overview of what we've done. I'd be happy to answer any questions.
Great. Thank you so much, Toni.
Lisa?
Right.
So just a quick question, maybe I missed it, but are your ER providers, are they all physicians? Do you have NPPAs that are also part of that group?
All of the above.
Okay.
So we have physicians, we have PAs, we have NPs. Yeah.
I thought your presentation was fascinating and spot on. And if we had just changed the logo in the bottom corner to UPHS Marquette, it would have been the exact same story, you know, all the way down to housing and challenges with recruiting. So very interesting to me.
Yep, it is. I mean, I think many places in rural Michigan have the same challenges.
Can I, since you're unmuted there, Lisa, can I just ask, have you also implemented a lot of the things that Toni's talked about in her presentation, or do you have others to share as well?
We ended up putting a provider in triage, a PIT person that floats. It's usually our PAs that are there that will float up front, but exactly the same depending on the acuity and volume in the emergency department. And that's made a big difference. We also have started having they're not called ED techs or like ED assistants, but it's basically the same sort of thing that can start the EKG to decrease the time for the, you know, time to arrival to the, you know, EKG for those chest pain patients and all that. Our patient satisfaction scores in our ED are really good recently. You know, we have the same challenges with long boarding times and sometimes we get very congested too with trying to get patients upstairs or getting the patients that are upstairs out because of all those same challenges. So, you know, our LWATs kind of hover always not exactly where we want them to be. I'm intrigued about the volunteer. We do have a volunteer, you know, desk that kind of directs people coming in, but not in the ED. It's kind of in the main hospital area. So that's a really great thought.
Thank you for sharing.
We also opened up a behavioral health unit in 2023. It's been just a little over a year that it's been open. And that really helped to get some of those behavioral health patients out of our ED.
Yeah, you had mentioned that you had some of your behavioral health patients staying like 2 weeks in. So I was curious about how that was going, if you've seen an improvement there.
Yeah, we still have extremely long adolescent behavioral health is such a huge problem. We just got a young man out of our ED who had been there for 10 days.
Oh,
Yeah, very similar for us too. We have inpatient behavioral health. And so usually if they qualify, they're those adult patients are not too long, especially we have change of directorship in that unit, and that's been very helpful. But at any time that there's a youth, they're always leaving, and those are the really long ones.
I think that is a struggle across the board too, not just in the rural areas, but also in some of the more suburban and urban areas. We hear lots from them too. So that's unfortunate and difficult, but glad to hear that you guys are able to have some different strategies to address it.
I think one of the things that struck me from your presentation, Toni, was how you integrated community resources from your student nurses to your volunteers, your community volunteers. And I was curious, other than Lisa, if anyone else on the call had also been able to kind of capitalize on community-based resources like that in their ED or in other locations to kind of optimize just hands on deck, honestly. Doesn't sound like it. Let's see. Abigail did send in a question. She thanked Toni for a great presentation. Interested in how you determined that these were the solutions for your prolonged ED waiting times. Did you perform a walkthrough, tracer, other root cause analyses?
There were a lot of RCAs done along the way based on individual patient problems, but really what we did is we did a lit search. We were looking for best practices, and we made a list of best practices, and we identified of these best practices, which ones are most likely to, which ones do we have the resources to implement. And then we just started implementing it. It was sort of like we didn't know which one was going to work. So we just like threw it all against the wall and to see what stuck. I did take one thing out because when I talked to the ED director this week, she says, yeah, we're not doing that anymore. We were like making announcements in the waiting room, like the average wait time is blah, 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 blah. And that didn't help. And it created anxiety for those people who were, the sickest. So they stopped doing that. So, it's just, you never know what's going to make the biggest difference. And honestly, if I had to say one thing, other than fast tracking and the physicians, going out to the waiting rooms, rounding, taking people into the visitor ante room as an alternative to triage, I would say really the volunteers and student nurses. It was huge. It was just another pair of hands. We always think we need 2 more RNs, but when you have people who do things to support nurses, it can sometimes make just as big a difference. Lisa, we love having Gar up here, down here.
All
Hi,
right,
this is
I can get off mute fast enough. I'm glad that he's able to be, close to his family. I'm sure he's welcome and enjoying his time there too.
my name is Jennifer, and I'm from University of Michigan Health Sparrow, and we implemented, I'm curious how many other hospitals did this. We have Epic, and we implemented a on my way through my chart, you can alert the ED that, hey, I'm coming. And I was just curious if any other hospitals did that. While it was launched, not many people have really taken advantage of using that tool. So I was just curious if any other hospitals had experience with it.
Jennifer, actually, we did that several years ago. And they're looking at relaunching it now. People thought it was like a reservation. Like we would post out there on the web, like this is the average wait time, and put your name in, and then they would come, and we would have 3 ambulances show up with a huge trauma, and they would end up waiting anyway. So didn't really love the process. They're looking at it again and seeing if they can make it better, but yeah.
Jennifer, I'm curious if you can speak at all to like the acuity level of patients that have used that program. Do you know of any stats with that? I'm wondering if it's more popular with lower acuity patients versus higher acuity patients.
That simply has not been used enough to even give you any like, oh, here's the top, or this is the top reason complaint why patients are
Sure.
going to my chart to
Mhm.
look to see how busy the ED is and then say, hey, I'm on my way. I think when people are in crisis, they're just like 911, call an ambulance, take me to the ED, something along those lines. But I know that we have lower acuity patients that come in for sure. But they're not utilizing it. We're just not seeing that use at our small hospitals.
Yeah.
Emily, your question made me think about something that I'm wondering about with folks that do work a little more closely with the ED and kind of partnerships with like physician organizations or community primary care offices and things like that, and kind of trying to work together for solutions on some of these things. And I'll just give you a little bit more context for where this question is coming from. I recently was trying to get one of my kids in to see the doctor, and they didn't have any available appointments. And I know a lot of people, when that happens, or if they don't have a primary care, what have you, just go kind of use the emergency department as primary care for some of those types of things. They actually kind of helped us navigate to an urgent care that was nearby to try to kind of prevent us from kind of going to the ED and that kind of stuff. So wondering if anybody on the call has done any work with their local primary care offices or physician organizations to try to address some of these things. I know there's also not an abundance of urgent care, so it may not even be as good of an option, but.
We do have urgent cares, and we do a lot of advertising on billboards about our urgent care, but you have to be careful not to compete with primary care practices.
Yeah.
Okay. Do we have any other questions related to Toni's presentation today? Okay. All right. Well, then I will finish out our presentation, but just letting you know about a few upcoming work groups. Like I mentioned before, this is closing out 2024, but not to fear. We've got lots of work groups coming to you in 2025. In 2025, as has been mentioned in a couple other venues, we're no longer going to require attendance to an entire series of our work groups on a particular topic. So, for example, your attendance today completes the Rural Health series with MVC. But we're still going to be offering multiple work groups throughout the year on the same topic areas that were presented in 2024, including rural health. So these are the 3 dates for the 2025 rural health focused work groups that we'll be offering. So that'll be in March, July, and November. And to start out the new year, January's work groups are going to be focused on sepsis with a presentation from Sammy Banat from McLaren Flint Hospital. And we'll have a health and action work group at the very end of January with a presentation from Amanda Biskner from Tri-Hospital EMS in Port Huron. If you are interested in ED work, that might be something you might want to attend. And that completes our work group series for 2024. We really look forward to seeing you in 2025. Rachel will drop the link for our survey in the chat if you can grab that. Please be sure to submit that survey if you are seeking P4P credit for your attendance today. Please include the hospital that you have attended on behalf of. Each attendee can complete 1 survey for 1 site.